Society meetings twice a year now. And so we've already chosen our date. So the next meeting is going to be September 7th. You're putting that on your calendar.
Delafield,
Where is it, Angela? In Delafield? Delafield Inn? Okay. And we thought it would be a little closer for our Madison colleagues to come. So, all right. Ty is going to introduce our speaker.
so it's really my pleasure to introduce our speaker for this evening, Dr. Katznelson. So I really had a fantastic day with him today. I guess the obligatory educational information. So he received his medical degree from UCLA, did an internal medicine training at Penn, before endocrine training in Boston, and then went to Stanford, where he is currently a professor in neurosurgery and endocrinology, and is also the associate dean for graduate medical education. And we had some fantastic discussions today about medical education, and really has given me some excellent ideas as an educator and the fellowship program director. So I'm really excited tonight to hear about his topics in hypopituitarism. This work? Yeah, that was good. So,
Okay. Thank you so much, Ty and Diana, for inviting me. And it's been a great opportunity. It's my first time here, and it's been beautiful weather. Thank you so much. And it's a chance for me to see old friends, seeing Jay Finley, who I see way too infrequently. And also, I want to welcome my dear friend Adriana, who is now joining the ranks here in Pituitary. I had no idea Adriana was here until we were exchanging communication recently. She said, "I'll see you in Milwaukee." And I said, "Why?" And so I'm here now. I'm from Stanford, a director of Pituitary program. I spent a lot of my time doing that. I spent a lot of my time also doing graduate medical education. I was a former program director in the endocrinology fellowship, so happy to answer questions. We've had some great conversations. I want to thank the fellows who are here for an interesting lunch. I really enjoyed discussing what they see in terms of medical education. I'm not going to be discussing that tonight. This is all endocrine, but I just wanted to show my appreciation to you. Apparently, the ad went out that I was seeking on acromegaly, and if that was the case, we're talking about growth hormone, just a little less of it. And so if we want to talk about growth hormone and acromegaly, happy to do that. But I, in the interim, put together a little spiel on low growth hormone. So that's happy to cover more. I'm pushing the button. I'm pushing every button. I'm going to kick it. Okay, wait.
Yeah.
Thank you. So there's the three topics. I put topics because I want to make sure I cover a couple different things. I'm going to talk a little bit about the traumatic brain injury work we've done and some of the clinical work I do, in part because I started that work when I came to Stanford. So I was in Boston, I was at Mass General, and where I did my training, I was on faculty, and we were starting to see these patients with brain injury who had hypopituitarism. And when I came to Stanford, I was in both the neurosurgery and medicine departments, and thought there's a great first off starting way to merge what we did to create a program that involved both neurosurgery and medicine, and it really left off with research and funding that we got over time. I'm going to spend a few minutes talking about hypopituitarism and fertility in women. This is a topic that comes up quite a bit in those of us who take care of patients who are hypopit. It's an interesting literature, and again, we've had quite a bit of experience in this now. I want to go over some of that with you. And at the last part, for those of us who take care of patients following pituitary surgery, I'm going to show some work that one of our junior faculty has done at Stanford recently on management of hyponatremia, what we've done to reduce readmission rates. So I'm going to talk a little bit about that as well. This is a slide that most people here should be aware of. It's just basic growth hormone physiology, where the anterior pituitary gland produces growth hormone in a pulsatile fashion under stimulus by growth hormone releasing hormone and inhibitory control by somatostatin, resulting in this pulsatile secretion of growth hormone. And by the way, I was thinking about talking about Cushing's, but with Jay Finley in the audience, I thought that probably would not be a smart thing to do. So I stuck with growth hormone. Anyway, growth hormone circulates through the body, goes to the liver, where it tells the liver to produce insulin-like growth factor 1. It also produces insulin-like growth factor 1 locally at the tissue level. So we measure IGF-1 that's produced by the liver, but it's also produced, it's the main mediator of growth hormone produced in the tissues, allowing for long bone growth as well as all the other tissue effects. And in so doing, growth hormone, particularly with hypopituitarism, is not something that we can measure. It's going to be low even in normals during the day. It's produced mostly at night during deep wave sleep. And so assuming we're measuring growth hormone levels during the day, it's going to be low in all of us. And even if it's pulses, it's still low. So it's not useful for assessing people who have potential growth hormone deficiency. Just to say for a minute, those of us who are thinking about hypopituitarism or growth hormone deficiency, there are just innumerable number of causes that can lead to both of these. The main ones are tumors. Those are the ones we tend to see in our clinics. Any kind of cellular lesion. Growth hormone is probably, of the pituitary hormones, the most sensitive any perturbation of the pituitary gland. So I've listed a bunch of different disorders here. Radiation to the pituitary gland. This is, again, one of the most common forms of hypopituitarism that is seen in children. It could be seen within a year of basal skull radiation. Of course, will lead to short stature. Infiltrative diseases can do this to you. I will be speaking a little bit about the head trauma. I'm not going to be discussing more about the other causes. Hypophysitis is, of course, another cause. So there's a whole slew of causes of hypopituitarism. We're going to be speaking a little bit more about the head trauma piece of it. Now, the markers for growth hormone, the surrogate marker is IGF-1. We use this for acromegaly as well. So IGF-1 is almost like the hemoglobin A1C for growth hormone, and that because growth hormone levels are pulsatile, particularly on low end, we're talking about growth hormone deficiency, it's IGF-1 gives you a sense of what the growth hormone ambient levels have been for the past weeks. This has shown you a study from a gazillion years ago that looked at IGF-1 levels. And this gives you a sense that in patients who we know are growth hormone deficient, however they got there and however it was tested, IGF-1 tends to be low. So it is a marker for ambient growth hormone levels, but it's not perfect. If you look in this, and this has been shown by a number of other studies, including ones that I have done, it's normal in about 20% or so of patients. So it's usually in the low end of normal in those situations, like showing you in this graph here by age. And again, what this graph also shows you is that IGF-1 and growth hormone levels fall with age. It's a whole other subject about aging related to growth hormone relative deficiency in the somatopause. I'm happy to talk about that if there's questions at the end. But you can see that growth hormone levels tend to be, the IGF-1 levels, I should say, tend to be low in patients who are hypopit or growth hormone deficient, but not always low. When we make the diagnosis of growth hormone deficiency, it's important to realize there's different tests that we can use to make the assessment of growth hormone status. The insulin tolerance test has been traditionally considered the gold standard. How many people in this room have done an ITT for growth? Have any? A few? Yeah, I've done probably a few hundred of them. And, it's not an easy thing to do because MD has to be present, patients not too infrequently pass out. We were taught not to do it with anybody who's considered old, which we were told was 45 and above. So because old meant that there may be, occult cerebral coronary vascular disease and lead to ischemia or some other event. So it's not an easy thing to do. I'm not able to do it at Stanford because the place where the infusion unit where you could do it is nowhere near the clinic, so it's not feasible The arginine GH-RH test was one that we used for a long time. It was a very accurate test. There were cutoffs that were BMI dependent, and that's important because growth hormone not only varies with age, like the IGF-1, but growth hormone also varies by BMI as well as by gender. So there were cutoffs that were useful. The problem is growth hormone releasing hormone has not been available for pharmacologic use in the United States for a number of years now, which is really unfortunate. So commercially use, I should say. So we're not able to do that test. Most of us do the glucagon test. It's the easiest one to do, and it is one where patients tolerate it really well. They get the injection of glucagon. I'll show you about the timelines for that in a minute. And the cutoff is thought to be a level of 3, but there's some interesting data on patients who are overweight that we should be using lower cutoffs to lower the number of false positive results. The Maslow-Morellin tests, for those of you in this room who have done this test, it's an oral test. It's the relatively newest person on the block, and with regards to assessing for growth hormone, it's a growth hormone receptor secretagogue. It's a really terrific test. It's got 90% agreement with ITT. There are cutoff points, so I'm showing you here some specificity and sensitivity of this test. The problem with it, there's several problems. One is it's super expensive, and it is a test which many hospitals will not do because of its expense. We were allowed, for example, at Stanford, we could not do it in the inpatient arena because hospitals didn't want to pay. It had to be done in the outpatient arena. And even then, we couldn't always get support for doing this. The second one is, it was marketed by Novo Nordisk. It's no longer going to be marketed by them. So we're not really sure where it's going to be marketed going in the future. And that's only a few more months of us being marketed that we know of. So it's a really great medication with those sidebar limitations. Oops. And just thinking forward, for those of you who treat growth hormone deficiency, this is a slide that's well known. So there are a number of benefits of growth hormone to treat some of the deficits of growth hormone deficiency. In children, the main biological endpoint is height. So short stature is how this presents in kids. But in adults who have already completed growth and the bone plates have fused and adult growth has been achieved, the height is not the issue. It's just more of these other categories of potential benefits of growth hormone deficiency. One has been quality of life. And there's data from decades ago that showed that kids who are growth hormone deficient, let's say they were, isolated growth hormone deficiency with short stature, they're treated with growth hormone. The pediatric endocrinologists in this room could speak a lot smarter about this than I can, but they're treated with growth hormone until it stops somewhere in high school years when the kid has reached the appropriate peak or predicted height. And then it's usually stopped because the kids just don't want to do these daily shots anymore. But there's a proportion of these kids, we track them through adulthood, don't fare very well. They have a harder time being successful in life, however you define it, whether it is in holding jobs, living independently, relationships, the quality of life seems to take a downturn. And that turns out to be in adults with growth hormone deficiency, one of the main kind of defining phenotypes that are problematic for these patients. Not only do they notice that they have this lower quality of life, which can actually also present with depression, it can present with cognitive dysfunction, and that there's a number of these patients who have growth hormone deficiency lose short-term memory recall. I'm happy to talk more about that too. We've done some functional imaging studies looking at this in patients. They have lower short-term memory recall, that's good attention span. Some three-dimensional thinking can be impacted, and a lot of these can be improved upon giving growth hormone back. So there clearly is impact of the growth hormone deficiency on the person. On bone metabolism, height isn't the issue, but bone metabolism is, and these patients may have osteopenia, if not frank osteoporosis. And there was a while there that growth hormone was the only anabolic substance that we would give to patients who were growth hormone deficient and had osteopenia, osteoporosis. In terms of the body composition, adipose tissue and skeletal muscle are impacted by this. So growth hormone deficient patients lose muscle mass and gain fat mass. The exact opposite happens when you give growth hormone. And this is one of the reasons why growth hormone is abused by athletes, because of its major anabolic effect on on muscle, and it's very lipolytic, so patients, they lose a lot of fat stores, particularly around the abdomen, and get bigger muscles. So those are some of the main things. The other components of growth hormone are cardiovascular risk, and there are plenty of data that growth hormone may improve vascular distensibility, lipid profiles, so cardiovascular risk in patients. But these are the ones I'm showing you here, are the main reasons we consider treatment for growth hormone deficient patients. Not all patients with growth hormone deficiency need to be treated, but those we look for reasons, often we look for reasons to treat them. Start with the case of thinking through this. Again, I'm not going to speak in this part of the talk, not about hypopituitarism in general. I'm going to be focusing more on the growth hormone deficiency. It's not something that many endocrinologists think about, and I thought it'd be reasonable to discuss now. So this is a 33-year-old male, presents with fatigue, increase in abdominal girth, sexual dysfunction, and weight gain. Now, about 14 months prior, he had severe head trauma from a motor vehicle accident. He had cerebral edema, small hemorrhage, and was in the hospital, coma for 10 days, transferred to rehab facility once stable, and he has since had extensive rehabilitation, both inpatient and outpatient. But he comes now because he's just wondering why he's not convalescing, why he's not gaining strength, why he's still tired, and asks, is there a reason? He's on Provigil because his energy is so low. And his labs, you see here is a normal TSH, normal free T4. His testosterone is slightly low, moderately low, I should say, at 130. Normal's, let's say, 280 and above. And his IGF-1 is low as well. For a 33-year-old male, that's a low IGF-1. He has a cord stim with a normal result, cortisol's 25. So these labs look like moderate hypogonadism and an IGF-1 level that should be in the 300 range or 200 range for someone who is 30 in his 30s. Just to say a little bit about TBI to see where this thinking comes from. TBI is, of course, a huge problem. Internationally, it accounts for an interesting, or United States, 2.2 million ED visits annually, many hospitalizations. The highest rates of TBI are found in older adults, followed by young children. If you look for the cause of what leads to, for growth hormone deficiency leads to TBI, in adults, it tends to be, it can be motor vehicle accidents, but there's also other forms of brain injury, including abuse in children, or sports in children, can be a form of TBI that leads to hypopituitarism. So it's not a minor thing out there in the community, a minor problem. And when you think about what the brain injury does, there are direct primary injuries, such as penetrating brain injury versus blunt head trauma. And of course, if there's penetrating injury, that can lead to dysfunction of pituitary gland, just sheer penetration. There could also be hemorrhage and edema that can happen just from any kind of brain injury. And then there's a secondary injury, which could be like a counter-coup type of event, where there could be ischemia. And one of the interesting things that's been a focus of research has been the impact of ischemia on inflammatory changes within the pituitary gland, leading to cytokine generation. I'm going to show you some of the data on anti-hypothalamic, anti-pituitary antibodies, presumably because of inflammation that causes the release of antigen from the pituitary and hypothalamus, leading to antibody generation. It's been considered, but hasn't been a strong case for, as a biomarker for who has brain injury may develop pituitary dysfunction. And the ApoE genotype has been another interesting piece of this that tends to be a marker for someone who may or may not have hypopituitarism from brain injury. And the autoimmunity story is still being evaluated. There are some data from Turkey, mostly, that have looked at this, that have looked at both anti-hypothalamic and anti-pituitary antibodies in patients who have brain injury, asking the question, does this correlate at all with the presence of hypopituitarism now or in the future? Can it be prognostic? Kind of similar to antibodies to insulin or to the pancreas. And this is an example of a study that showed that if you look at controls, you don't see these antibodies, but in patients who have had brain injury, you can't. And it tends to be that patients who are hypopit tend to have more of these antibodies, but it's too much of a tendency. It's not a yes or no phenomenon So more work is being done, but it's an interesting way of thinking about how you can prognosticate who will become hypopit. Now, when I saw this study around the time that I moved from Boston to Stanford, it made me start thinking about the prevalence of hypopituitarism in patients who had brain injury. And here's an example of one of the studies that came out of Italy that looked at hypopituitarism in patients who've had either TBI or subarachnoid hemorrhage. And interestingly, the subarachnoid hemorrhage story is it looks like the prevalence is even higher in patients who have spasm following the subarachnoid hemorrhage, but nevertheless, it still can cause it itself without even having the vasospasm. And as you see here, the most common hypopituitary axis here is the growth hormone as the most common, like with all other injury of the pituitary glands, growth hormone deficiency is the most common seen. In this study, followed by hypogonadism and the other pituitary indices seen in in traumatic brain injury. And this kind of led to some of the thinking. This wasn't the first paper, but it was one of the major first ones that looked at prevalence, made us start thinking, does hypopituitarism impact convalescence and particularly growth hormone deficiency? But all these hormones impact convalescence for someone who's trying to heal from brain injury. And they asked the question, should there be a role for growth hormone deficiency? And this kind of got us going. And then I had one of my fellows start to do a project with me where we started collecting data on patients who had brain injury. This is one of the first studies we did on brain injury and subarachnoid hemorrhage. And all we were asking was, what's the prevalence of hypopituitarism in this population we were using in this case, the growth hormone GHRH arginine stimulation test, because we had GHRH available back then for stimulating growth hormone. And these were all patients with moderate to severe brain injuries. So this is not a concussion. These are patients with moderate to severe injury. I'm showing here the data that growth hormone deficiency was found in about 20% of the patients, a lot of adrenal insufficiency, and I don't believe any of that. And the reason why that shows so much is at the time, there was a lot of us thinking about changing the paradigm of how we assess adrenal function. And this was this low dose cord stim. And if those of you who have done this, the idea was that maybe the 250 microgram corticotropin dose that we use for the cord stim is just too high. And you're going to have normal results and you won't be able to pick up subtle defects in adrenal function. So maybe we should be using a lower dose of corticotropin. And that's what this was. But the problem was it was super sensitive in picking up adrenal insufficiency. I don't think there was adrenal insufficiency. So that's what these data, I don't believe that half of them were adrenal insufficient, but that's the results we had. And I haven't done that test since after the study. What we found in those patients was that the growth hormone peak after GHRH did correlate with physical independence, mobility, functional ability. So there did seem to be a correlation of the growth hormone deficiency in these patients with functional outcomes in patients with traumatic brain injury. We started looking more at the fatigue aspect, because those of you who've seen patients with TBI, many of them are fatigued. There's a fatigue that kind of goes along with this. And the question we were asking, how much of this is due to pituitary dysfunction? How much of it is due to the fact that they had traumatic brain injury with parenchymal damage? And so we know that fatigue is present in the majority of patients who've had brain injury of all types. And we're looking here at moderate to severe brain injury. And we know that the fatigue tends to persist in these patients. And the mechanisms of the fatigue wasn't clear. Again, was this related to the parenchymal damage in the pituitary, in the brain, or how much of this was due to associated sleep disorders or depression secondary to traumatic brain injury, or was it due to neuroendocrine dysfunction? These are the questions that we were asking. So I collaborated with our local rehab center there was a county hospital in Santa Clara, which is not too far from where I am in Palo Alto. And they have one of the major brain rehab facilities in the area. And we started doing glucagon stimulation tests on the pituitary hormone measurements in their patients for the rehab center. And so we had 119 patients in this study. And most of these patients were motor vehicle accident patients, as a lot of them are. And these patients were on antidepressants, so a lot of them had depression. And about half of them scored high fatigue measures. So again, it's pretty common to see fatigue in this patient population. And we did cord stims, and about a third of them of course, we've done a glucagon stimulation test in these patients, but a third of them had growth hormone deficiency based on classic criteria. And another group of them had kind of modest growth hormone deficiency, if you define it that way, meaning that they didn't meet classic growth hormone deficiency, but the growth hormone levels didn't rise as high as some others. And 20% of them have overtly low IGF-1s. But the bottom line is we couldn't find any correlation of the IGF-1 or the peak growth hormones results or the presence or absence of growth hormone deficiency with fatigue. So we were never able to make a connection with the fatigue, which is unfortunate because that would kind of push us to think about it more, but that's what we found. Fatigue appeared not to be related to neuroendocrine dysfunction. Now, what are the risk factors in these patients? That, it was thought that you tend to see this in patients who are severe. So these are patients hospitalized, have significant brain injury, and it tends to be seen in those patients more so who have cerebral edema or have hemorrhage, cerebral hemorrhage, likely causing vasospasm of the hypophyseal system, resulting in the pituitary ischemia and all the effects we just said. But you can see this with mild trauma. You can see this with concussion. So usually people who have passed out, but do not have long-term sequelae of concussion. They can't be seen. And I mean, there was a meta-analysis I'm showing here. This is from many years ago that showed, again, you can see this with mild traumatic brain injury. The problem has been there have been no good studies that have really tried to look at the concussion patients, or trying to correlate concussion with presence of hypopituitarism or growth hormone deficiency. So many people have concussions, and very few of them likely have true hypopituitarism. But the question is, who are those patients? And so people started looking at athletes. There was a study from years ago in, I'm not showing here, from Turkey, looking at retired boxers. And those people, they get a concussion every time they're out there. I mean, they're just hitting themselves in the head, right? So they're getting concussions. And those patients, about 20-25% of them had growth hormone deficiency. And also they had, they had growth hormone deficiency. What I'm showing you here is some of the work that Dan Kelly from Los Angeles did, looking at NFL players. So I was involved with this sort of briefly because I was trying to help them come up with a growth hormone deficiency protocol to use. They ended up using glucagon, and they looked at, it was not a simple thing. Dan was able to get funding from the National Football League to do this, and you can imagine they weren't too excited about demonstrating that the retired players were growing on deficiency. So it was not a simple thing getting funding from them. He was ultimately able to do that. It's like I wanted to do work on collegiate football players, so I went to the Stanford coaches and asked if I could do work with them, see if they were, because they were having concussions, asking if they were getting growth hormone deficiency, and you can imagine the enthusiasm I got in the response. So my studies, at least the Stanford football team, didn't go very far. But so this team was able to get some funding to do this, and we were able to recruit NFL players, 68, who were mean age 47, so this is past retirement age. I guess I'm just too lady, but for everybody else, this is like old football players. And they found hypopituitarism in 24% and isolated GHD in 15%. So it was very present. And so the idea was that repetitive concussion is associated with hypopituitarism. They did some studies of the quality of life. It's kind of hard to figure out the impacts of quality of life between the football days and those of the growth hormone deficiency, but there was some suggestion that there was some functional changes maybe related to the growth hormone deficiency. So the idea is repetitive concussions can cause hypopituitarism and growth hormone deficiency. Does a single concussion do this? And many of you probably have referred patients like this, and the answer is we just don't know. And if they're fatigued, maybe, but likely not related. In summary, complete or partial hypopituitarism may occur with all levels of TBI, but more commonly likely in the moderate to severe brain injury category. And that many of the symptoms of hypopituitarism overlap with just those that occur with traumatic brain injury. The fatigue, there's no good proof, and others have looked at this as well, and they have not seen a correlation of fatigue in TBI patients with hypopituitarism. So what I do for these patients, it was a great opportunity for me when I started my pituitary program at Stanford to work with the neurosurgery group. So I work with both, and for years I've done this. So I work with the vascular neurosurgeons for the subarachnoid hemorrhage patients, and for the trauma surgeons for the traumatic brain injury story. If referring to me, I wait for at least 12 months after the event because there's some data that acute growth hormone deficiency and acute hypopituitarism can improve over that year. So if after 12 months, they're still feeling difficulty or challenges with convalescing, I do see them do pituitary testing. I would say pick up growth hormone deficiency, just like in the literature, 15–20%, somewhere in there. But when you do find it and you do administer it, there can often be benefit results. So that's how I've done my practice. And it was a great opportunity for me to work between medicine and neurosurgery to create this collaboration for the patients. All right, I'm going to move to a different topic. Very different brain injury, very, very different. And this is something that those of us who see hypopituitarism think about because it's a problem for both men and women who are hypopit, who are of age where they won't have children and dying to do it, but men have azoospermia. I'm not going to talk about those tonight, but happy to talk about that. And the women have infertility. And so what can you do about these patients? So what is the literature on that and what happens with the pregnancy? I'll talk about 3 parts to this. One is the impact of hypopituitarism on fertility. The other one is their value of growth hormone. So back to the growth hormone theme, the value of growth hormone in these patients. And what is the impact of hypopituitarism on the pregnancy outcomes? Important aspects for these patients who, if they're hypopit, it's going to happen when they get pregnant. Essentially, fertility is, of course, a problem in somebody who has hypogonadotrophic hypogonadism. If they don't have ovulation FSH, they're not going to have ovulation naturally, and they're going to need some assistance to do this. So natural pregnancy in women who have amenorrhea and hypogonadotrophic hypogonadism, it's rare for these women to become spontaneously pregnant, and they need assisted reproductive treatment. They need ART because otherwise, and even if you do this, it's not a simple thing. There are fewer ovulatory cycles, prolonged stimulation duration until they ovulate. So for those of us who work with reproductive endocrine type of people, the REI people, these patients can be tricky to undergo ovulation induction. And also what's found is this tendency to poor outcomes when hypopituitarism is found at a young age. So if a woman is hypopit starting in their teens, they're trying to get pregnant now, mid to later 20s, for example, outcomes are tricky, not as good as they are if this happens later for reasons are a little obscure, but I'll tell you something. Here's an example of 5 women who are hypopit. It may be hard to see, so I'll walk through this. 5 women who are hypopit and underwent various technologies using ART to become pregnant. They were all on hormone replacement, receiving growth hormone as well. And it just goes to show that it is possible for these women to conceive. They need to have sufficient pituitary hormone replacement. And in this case, in these series, require growth hormone replacement as well. And we'll come back to the requirements of growth hormone in a minute, but it just shows it is possible to undergo ovulation induction in women who are hypopit and be successful. There are a number of mechanisms that have been purported of underlying this infertility associated with hypogonadotrophic hypogonadism. We know that the oocyte reserve is low. AMH levels, which are a marker for ovarian reserve, tend to be low in this patient population, particularly low in those adult women who had growth hormone deficiency or hypopituitarism starting as children. So again, there's this thinking out there that for those kids or teenagers that become hypopit, they're going to have the greatest difficulty with ovarian stimulation down the line. Now, although AMH levels are low in these patients, there is no cutoff. There's variability in this, and there's overlap of AMH levels between those ones who are successful, those who are not. So it's not clear we can use AMH levels in so doing, but it is interesting that there's an overall correlation. So we know in these women, they will require gonadotropin therapy if they're hypogonadotrophic hypogonadal. And so the question has come up the role of growth hormone in these women. I'm just going to give you some of my thinking on the approach to this. We know that growth hormone does a lot of things in both the ovaries and in the testicles. And in the ovaries, it binds to a number of the cells within the ovary. It enhances steroid synthesis and metabolism. It affects follicle and gamete maturation and inhibits follicular apoptosis. So growth hormone does have a lot of in vitro effects that may explain why there may be benefit of growth hormone in this population. I'm showing you a case of N-of-1, just one case, where it was an interesting study that looked at, this is back, when was this published? Not sure, I forgot to put that in there. It was a while ago. And the growth hormone deficiency was present in this woman. And when they found, when they did biopsy, that the oocytes seemed to be abnormal, they seemed to be immature in such patients. This woman underwent ovulation induction unsuccessful, then started growth hormone, and 3 months later had a successful ovulation induction. N-of-1, take it for what it's worth. But this was an interesting study because it tried to look at oocyte maturation before and then success afterwards. Healthy baby was born in this N-of-1. And I'm going to just summarize a bunch of data for you and just to say that there have been a number of studies that have also shown, and this has been my experience clinically as well, that women who are hypopit and hypogonadotropic hypogonadal that undergo ovulation induction, that it is often not successful until growth hormone is administered. Now, growth hormone is not required for this process. Women can get pregnant without being on growth hormone therapy, but it may be beneficial. What I do in my practice is in any of my hypopit women that are thinking about undergoing ovulation induction, I'm assuming I've replaced the thyroid, I've replaced the cortisone, I've done all that. If they are contemplating ovulation induction and they're growth hormone deficient, which they usually are if the other axes are not there, I generally do give growth hormone replacement. We could talk about how long you continue it in pregnancy once they're pregnant, but I do give growth hormone replacement. And it doesn't work every time, but we've had a lot of success doing it. I can't prove it's made a difference, but I'm given the expense, both physically and economically and emotionally, that women go through when they're undergoing ovulation induction. I think it's a pretty easy thing to do, at least in the short term, while they're undergoing the induction therapy. I want to talk a little bit about what happens to these women once they conceive. So there have been several relatively large studies that have tried to look at, this is one of the smallest that have looked at, what happens to these women once they get pregnant? Do they carry the pregnancy normally? What happens? And this is a study that looked at hypopit women with published controls as the controls, so it wasn't their own controls. But what they found was in this retrospective review that those women who were hypopit, again, compared to historical literature controls, that there's a higher chance of small gestational age children, transverse lie, and a theme that keeps coming up is the need for cesarean delivery. Almost all the kids that come from mothers who are hypopit require cesarean section. It's an interesting thing, which no one really has understood. People have contemplated that this is due to oxytocin deficiency, if such exists, but that has not been quite clear either. And so with other studies, the transverse lie, uterine inertia has been thought to be significantly hampered in the presence of hypopituitarism. And again, the fact that many of these women have cesarean section. And I said a minute ago, people have thought, could this be due to deficiency? For example, women who have diabetes insipidus and are pregnant, does that make them higher risk of having cesarean section? It's not clear. There was one study, it's shown in mice that mice deliver babies fine, no matter what the situation, oxytocin or no. And there is, at least in my house, that appears to be the case. And there was one case where a publication of someone who was administered, a woman who was hypopit, was administered oxytocin starting the 34th week. Didn't matter. She still needed oxytocin. She still needed a cesarean section. So N-of-1. So it's not really clear if oxytocin will make a difference in these situations. It's tantalizing to think that's part of the reason this is happening, but we really don't know. Here's an example of 18 pregnant pregnancies in 9 hypopit women. This is published a number of years ago that showed that miscarriage rate was about 30%, which may be kind of similar to other situations. Cesarean rate was also 100% in these patients, so they do require cesarean. And half the live births were only below the 10th centile weight, so the small for age children appears to be a problem with hypopit mothers. So in summary, for this portion of my talk, hypopit women have lower pregnancy rates and higher miscarriage rates than it seems the general population. Of course, they require gonadotropin therapy if they're hypogonadotropin, hypogonadal. And the role of growth hormone replacement is not clear. It's not required for women to get pregnant. I tend to use it, as I said earlier, for all the reasons I described, for women who are growth hormone deficient. We already know that growth hormone has a role in women who are normal growth hormone, who are high risk, like older women, women who've had a lot of difficulty getting pregnant. REI clinics routinely use growth hormone in patient populations. We're talking here about growth hormone deficient. We talked about they often require cesarean section for reasons that are obscure. So I bring this up to you, this data, because it's something, again, we see quite a bit of in my patients. A lot of our patients who are young women who are interested in fertility and in pregnancy, these are the issues that we discussed with them. Now, moving to another topic, third and last topic for you guys is on post-op management of pituitary problems, also hypopit, that's the theme. And I want to show you some data on a post-op protocol that we use for the pituitary surgeries and how that's made a difference for us. I'm going to show you something that I'm sure all of you know, that the triphasic response of fluid electrolytes after pituitary surgeries, that in the first days after surgery, the risk of diabetes insipidus, presumably due to maybe ischemia, swelling of the pituitary gland after being bumped with various tools. And so the DI that occurs, followed by the second phase. And for those of you who are fellows, this likely will be on your boards and was on, I can tell you, board review, which I ran last year on this. So the SIDH phase, the hyponatremia phase that follows this, and this can occur somewhere around 20% of people. It can be a variable degree. We're going to be talking about that in a minute. The SIDH phase, which can be followed by DI, which if it happens in the third phase, can be long-standing at that point because it often implies complete neuronal degeneration. You can see at least one aspect of this, and up to 30–40% of patients after pituitary surgeries. You can see 0, 1, 2, or all 3 of these. In general, we often see maybe DI and SIDH, but unless the entire gland has been resected, and the surgeon will tell you that right after surgery, you usually don't see the third component of DI. Leah Chang just graduated from a fellowship last year, and she came on faculty. And when she was a fellow, she was interested in, well, actually, she's been a faculty now 2 years, and her second year. And when she was a fellow, she became interested in pituitary work. And we had admitted some really severe hyponatremia patients after, I'm sure you happened to do, after the surgeries. And around that time, we had started our protocol of fluid restriction. I'm going to talk about that in a second. And to see, and so the problem was that this hyponatremia occurs, as I told you, but our readmission rate is 8%, which seems pretty high for patients who had pituitary surgery being readmitted because of severe hyponatremia post-op. And severe hyponatremia, meaning sodium less than 124, occurring in almost 8% of our patients, which seemed like a lot in such patients. So the question we were asking is, what can we do to reduce this readmission rate? And a few years ago, many of you in this room know him. He used to work with me at Stanford, Ed Laws, who's been at the Brigham, just retired this past year. I think he's done more pituitary surgeries than anybody on this earth, maybe, or more than a lot of people. Well over 5,000, and maybe 6,000. I'm not sure. So Ed started this protocol at the Brigham of fluid restriction, just asking the question: if we were to send patients home from pituitary surgeries and limiting the amount of water they could drink, will that impact the prevalence of hyponatremia, and in the end, impact readmission rates. And so they looked at a retrospective study of 788 patients. I mean, Ed, just like you hear that Nate's doing here, just has a lot of patients at the belt, and he recruited a lot of patients. And they did a protocol where pre-2014, they did a lot of centers do. They just said, when you go home, just drink to thirst. And we'll do blood testing for sodium levels some days afterwards to make sure you're not hypo, and call us if you're sick, essentially. The intervention starting in 2015 was to fluid restrict 1 liter a day of the water they drank, starting on about day 2, day 3 after surgery, and continued for another 5-6 days. And what they found with their intervention in these patients, again, this is not a randomized study, this is retrospective up to 2014 and beyond, is that none of the patients were admitted for hyponatremia who were in the fluid restriction group, whereas 3.5% of those in the control group. So that was tantalizing. And a lot of us saw these data and started thinking maybe we should do something similar. And around 2020, we started doing something similar. And so again, before this time, these patients, when we sent them home, and I had done this all my years as training and practice, is just told patients to drink to thirst. That's what we told them. When you go home, if you're watching like the Golden State Warriors play, just drink to thirst. Don't drink more than that. And but after March 2020, we instituted this 1 liter fluid restriction protocol for post-op days, somewhere starting between 3 and 5, depending how the patient was doing, for about another 5 days was how long this protocol went for. I'm showing you here some of the raw data. It's kind of hard to see, so I'm going to walk through the points that I want to make. And if you look at the column, the third one, the fourth one from the right, it's sodium 120 to 124. The yellow is drink to thirst, and the gray next to it bar is fluid restriction. Starting with that sodium and moving to the right is where the sodium levels get even lower and lower and lower. Is that there was a difference, it was statistically significant, of prevalence of incidence of hyponatremia with whether someone did fluid restriction or drink thirst protocols. There's much lower prevalence of severe hyponatremia in the patients, it's maybe hard to see, the patients who were fluid restricted in this protocol. And even more importantly was the readmission rates. So when Julia did this, she got a grant from, we have a cell program. We have a program that we have in the hospital for QI initiatives. And she got $20,000 to do this, which is great for a hospital. And she did this study, and on the left, the yellow is the drink to thirst readmission rates overall were 8.5% versus a fluid restriction of a little shy of 3% in this protocol. So it looked like it was really impacting readmission rate. I'm showing you here a study that just came out this last year. That was a meta-analysis of the 6 studies that have looked at this. And that includes the Brigham experience. And the fluid restriction protocols vary. They were between 1 liter to 1.5 liters a day during this time period. And they found that there was a 4-fold reduction in significant hyponatremia with this production. But in this meta-analysis, there was no difference in readmission rates. But to be fair, and as the study itself says, that there's potential bias because the studies had the different medical centers had different approaches to who gets readmitted versus home management. Like we generally manage at home patients whose sodium is 125, 126, we don't bring them in, we've been through restriction, versus change in practice over time. And remember, these are retrospective studies, generally, in difference in patient populations, but nevertheless, it was interesting. So they did see in this meta-analysis significant difference in hyponatremia, but not a difference in remission rates like we had seen in like the Brigham Hospital. In our large retrospective cohort trial, we do use fluid restriction. It's not a simple method to apply to all patients, because if patients, for example, are quite thirsty after surgery and they're peeing a little bit more, do they have mild DI, or is this just because they have a dry mouth? And it's hard to tell. We may not put them on this protocol. So it's oftentimes not all patients that go home are going to be placed in this protocol for that reason, but we try to implement this protocol in most patients that are going home. And in our hands, it has made a difference. But again, we don't want to do this in anybody, for example, who's at risk for diabetes insipidus last thing we want to do, food restrict someone who has DI. So we look for patients who do not have any evidence of GI upon going home, and the nurses call them frequently. A nurse practitioner works with me. She calls these patients frequently just to make sure they're not having overt GI symptoms, because that's the case. Of course, we stop the food restriction protocol, tell them to drink to thirst, and maybe start DDAVP. But again, by the time we usually implement this, it's usually around day 3. That's kind of the coming out of the first phase, the time period of the first phase of the triphasic response. That's where I work. I'm going to stop there, and I want to thank you all for inviting me and for my trip here. And thank you so very much. And I'm happy if there's time for questions. But again, thank you.
So we can take any questions, because I'll start out quick. How long is continued pregnancy? So an interesting question.
Sure. So thank you, Ty. So growth hormone replacement and pregnant women. So first basic physiology. So there's a series of genes of these growth hormones, a normal growth hormone, this growth hormone variant. And it turns out that normal growth hormone, pituitary growth hormone, turns off. Sign at the end of the first trimester was the growth hormone variant, present also in the center starts to come on. So for some of the multiple rampage idea as well. So if you follow IHF hormones, pregnancy slowly go up, which is one reason why you can't use them management.